Julia Wood, and I'm here to talk to you today about perinatal mood and anxiety disorders with a focus on suicide and suicide screening. So as we talk today about suicide and suicide screening and prevention, I want to make you aware at the beginning about the fallacy of prediction. Basically, we cannot truly predict who is going to die of suicide. And the reason is this. As you can see from this graph here, in a survey of Americans, that 12.3 million people endorsed having serious suicidal thoughts in the past year, and close to 46,000 died of suicide. So when we're screening, we're really identifying the people at the bottom of this pyramid. We're identifying a large group of people who have suicidal thoughts, who may be thinking seriously about suicide. And we need to intervene with all of those people in order to try to prevent the relatively small number, comparatively, of deaths from suicide. So today, as I talk to you, I'm going to talk about 3 key ideas. First, we'll talk about suicide. We'll talk about the scope of the problem. Next, we'll talk about screening. I'll talk a little bit about screening for depression and a validated tool to screen for suicide. As I have traveled across Tennessee, I've learned that most of you are already using these tools, which I'm really glad to hear about. So lastly, we will talk about disposition and treatment, and I'll review the perinatal mood and anxiety disorders, talk a little bit about what we can do to treat and refer. So the scope of the problem. Suicide is a major problem in the United States. This data from 2023 shows that 49,000 people died by suicide. That's 1 person every 11 minutes. 12.8 million people seriously thought about suicide. 3.7 million people made a plan for suicide, and 1.5 million people attempted suicide. And the rates have increased over the past 10 years. In Tennessee, suicide was the 11th leading cause of death in 2022. It took 1,200 lives that year. Men are more likely than women to die of suicide, but women are more likely to attempt suicide. And this is because men are more likely to use a firearm in a suicide attempt. So this graph here shows you the leading causes of death across the United States. This is from 2020. And suicide is in green. As you can see, in the younger age groups from 10 to about 34, suicide is in the top 3 leading causes of death. So for those of us who are treating people of reproductive age, this is a big problem, and we need to be aware of this and paying attention to this. And suicide does not discriminate by race, as you can see from this graph. It affects everybody. And again, suicidal thoughts, suicide attempts, suicide planning disproportionately affects the young, the people who you are seeing the most. And the rates are increasing. As I said, suicide prediction is poor, and I want to talk a little bit about why. The biggest reason that it is hard to predict suicide with a screening tool is because suicide is a relatively rare event. So when we're looking at screening tools will tell you what is the sensitivity of the test and what is the specificity of a test. So the sensitivity, as a reminder, tells you the true positives, right? So who will screen in. And the specificity gives you the true negatives. But what you really want to know when you're sitting with somebody with a positive result is, what is the positive predictive value of this test? How likely is it that the person who has tested positive really has this illness? And that value is affected by the number of false positives, as you can see here. And if you have a rare event, even if you have a highly sensitive and specific test, you are going to get more false positives, and that is going to drive down the positive predictive value. So even if we had a better screening tool, it is hard for it to predict suicide. So let's talk for a minute about risk factors for suicide. As a reminder, when I'm talking about risk factors are not warning signs. Warning signs are things like giving away items to your loved ones, talking about suicide, talking to someone about your plans for suicide. These are warning signs. Risk factors are more static over time. Having a mood disorder is a risk factor for suicide. As you can see from this graph, people with major depression were much more likely to have suicidal thoughts, to make plans for suicide, or to make a suicide attempt. Substance use disorders, also a risk factor for suicide. As you can see here, again, people with a substance use disorder were much more likely to have suicidal thoughts, make suicide plans, or make a suicide attempt. Access to lethal means. As you can see here, the method matters. Over half of deaths by suicide involved a firearm. So we want to be talking to our patients about firearm safety, securing firearms, even temporarily giving them away to someone that they trust when they're in a high-risk time, knowing that when this time passes, they can feel confident that they can have them back again if they want to. And prior suicide attempts are a risk factor for future suicide attempts. So with the Columbia, the screening tool for suicide that I'll talk about a little bit, it does ask about prior attempts. And in my practice, where obviously I have more time to talk about these things with patients, I always ask follow-up questions when people tell me that they have had a suicide attempt in the past. I'm certainly going to be concerned about anybody who has had a past attempt, but it is helpful for me to know just how potentially lethal that attempt was. Fortunately, there are protective factors as well. And what we want to do is be paying attention to those protective factors, documenting them, and working to increase them for our patients. So effective mental health care is a protective factor for suicide. In this slide, I want you to pay attention to the far right-hand column. As you can see, these are people who died of suicide. And as you can see, only 24% of people on the whole was in treatment for a mental illness at the time of their death. So we have a lot of work that we can do here to make this better. Connectedness is another protective factor. We want to help our patients identify friends and family members and other connections in their community. Problem-solving skills through referrals to therapy, including therapy that actually teaches new skills like cognitive behavioral therapy, or especially dialectical behavioral therapy that I'll talk a little bit more about in a bit. We can help people develop more tools to manage their distress when they're in crisis. And contacts with caregivers can also be protective. We loom large in people's lives more than we sometimes realize. And so it's really important that we are reaching out to people if they don't come to appointments, perhaps between appointments, letting people know that we're there if they need help and that we care about them. So again, as we're screening, remember who we're identifying. We're identifying these people at the bottom of the pyramid who have had suicidal thoughts or who maybe have made plans for suicide, in the hope of intervening with all of those people in a way that can help prevent death. So the Maternal Mortality Review Committee in 2022 identified key opportunities for prevention. And these are ways in which we can intervene. Lack of referrals and coordination of care, lack of screenings, inadequate quality of care, or delays in treatment, and a lack of resources. So these are things that we can all work together to improve the care of our patients. So let's talk about screening. I am sure that you are familiar with the Edinburgh Postnatal Depression Scale, the EPDS. It is a 10-question questionnaire that asks about symptoms of depression that has been modified so that it is more applicable in the postpartum time. And if you're doing this questionnaire, which I'm sure you are, you know that question 10 says, "The thought of harming myself has occurred to me." And if you don't have another tool to help you here, it can be a little hard to know what to do when someone says yes to this, either yes quite often, sometimes. So that's where the Columbia comes in. So again, as I've traveled across Tennessee, I've learned that everybody I've talked to is using this questionnaire, and I'm really happy to hear that. This questionnaire asks further questions about suicide and walks you through these questions, and then gives you a risk score, a stratified risk score, so that you can develop an algorithm of what to do depending on how someone screens into this questionnaire. So as you can see, Question 1 simply asks, have you wished you were dead or wished you could go to sleep and not wake up? And question 2 asks, have you actually had thoughts of killing yourself? If someone says yes to either of these questions, you go on and ask more questions. Have you been thinking about how you might do this? Have you had these thoughts and some intention of acting on them? Have you started to work out or worked out the details of how to kill yourself? And do you intend to carry out this plan? You should also ask about past attempts. As you're developing your algorithm for what to do next, it's really important to have the 988 Suicide and Crisis Lifeline in your toolbox. Hopefully you are already familiar with this. If you are and you haven't used it, I just want to tell you a little bit about my experience with it because it has overwhelmingly been positive. So you can yourself call 988. If you are sitting with a patient and the patient is endorsing thoughts of suicide and you don't know what to do and you need more help, you can call a 988. They will walk you and the patient through the Columbia and they will help you come up with a plan on what to do. I have had a number of patients call the 988 hotline and have really good experiences. So I had a patient who called me on my way to work one morning. She called me through the after hours system and she had used the 988 number the night before. She'd been in a really dark place, didn't know who to call, had talked to them, and they had helped her come up with a plan to stay safe that night, to call me the next day, to make some other calls, and to get herself into some, positive activities that day. It was really helpful for her. It got her through a crisis. I met another patient when I was in a more acute care setting who had called 988 and he was in a really dangerous place. And so 988 had sent an ambulance out to his house and brought him to the hospital where he was admitted. And his experience had also been really positive. So when you're giving this number to patients, I would stress to them that they don't need to call this because they think they need to go to the hospital. They certainly can, but they can call this if they're having a tough time and need some help figuring out what to do next. This is a great resource for them. So now you've screened, let's talk about disposition and treatment. So in our risk stratification for the Columbia, if people answer yes to questions 4 or 5 or 6 in this red area, you want to get them immediate help. You can call 988, you can call 911, you can go to the emergency room. You really can't leave this person alone until they've had further evaluation and potentially been hospitalized. But if they answer yes to the low or the moderate risk questions and we have done a little bit of further talking and feel safe sending them home, we want to think about safety planning and what to do next. What you basically want to do is make a plan with someone around you're safe right now, but what would you do if things got worse? And really think it through with people. So obviously you want to share the number to 988 and talk to them about how to use it and what to expect. I would encourage you to ask them to pick 2 family members or friends that they can call and actually write down their names and write down their numbers and keep it somewhere that they can easily find. Because when you're in a crisis, your brain does not always work very well. So you really want that to be handy. You also want to talk to them about where they could go if they felt like they needed to go to the hospital. And that might mean, what emergency room should I go to? Are there hospitals that I can walk into without going through the emergency room? Are there crisis stabilization units that are voluntary and are not necessarily a locked inpatient unit? And you may also want to share with them the Postpartum Support International hotline and warm line. So Postpartum Support International is an organization that does a lot of support, education, connection of people to resources for families and individuals who are pregnant or in the postpartum period around mental health. And they have both a hotline where you can call and reach somebody immediately, as well as what they call a warm line. The warm line is if you're not in crisis, you actually leave a message and someone calls you back. But that you can get a lot of resources and support from them as well. You want to be following up with your higher risk patients. So that might mean a phone call from someone in the clinic the next day, follow up to make sure that they went to an appointment that you had set up with them. And you, of course, want to address lethal means reduction. So that means talking to people about firearms, asking if they have firearms in their home, talking to them about at least temporarily storing them in a way that is reducing accessibility, ideally getting them out of the house, and also talk about lethal medicine and how to store that in more safe ways and who might be able to help them around this. And then we want to document, because as I've said, even though there is this fallacy of prediction, we cannot necessarily know who is going to go on to make a suicide attempt and die of suicide. Medical malpractice does not necessarily lead us to believe that. So we want to document that we have really done everything we can to assess an individual's safety and make sure we're doing the right thing to get them into treatment and keep them safe. So first, we want to document the risk level. That is where the Columbia is so helpful, because it's a validated tool that tells you what the risk is. You want to document any protective factors. What I do really is, if somebody tells me that they're having thoughts of suicide, but they're not going to act on them, I say, what stops you? And most people will say, my family, my friends, someone in their life that they care about, that they know that this would have a really devastating impact on them. And so I document that. Again, you want to talk about any efforts you've made around means reduction, and you want to talk about a treatment plan. You want to talk about where you've referred someone, perhaps you've started medicine, what you think the diagnosis is, what you're going to do to help treat the underlying disorder. But with treatment, diagnosis is key. And that is where it's really hard, if you're not a psychiatric provider, to know what to do. And I know that everybody has some different comfort levels around this, but I want to talk a little bit about the perinatal mood and anxiety disorders, what they are, what appropriate treatment is, and how you might be able to differentiate a little bit between them and what you need to worry about and what you don't need to worry too much about. Perinatal mood and anxiety disorders are common. It is often cited that postpartum depression occurs in 1 in 5 women. If you are working in a clinic that is primarily treating people who have Medicaid, you may be wondering, what do you mean 1 in 5? I see 1 in 2, and you are correct. You can often see postpartum mood and anxiety disorders occurring as often as 50% of the time. So what are the perinatal mood and anxiety disorders? As I said, the most common and the most talked about is depression. And when I think about postpartum depression, I really, in my mind, think about it in 2 different groups of people, even though the presentation of the depression itself is no different in these 2 groups of people. But I think about people, there's one group of people who have no history of depression, who find themselves in the first year postpartum experiencing a depressive episode for the first time in their lives. And postpartum depression is often characterized by high anxiety. So people don't always say they feel depressed. Sometimes they say they feel really anxious. And it's hard to enjoy themselves. It's hard to bond with baby. It may be hard to sleep. It may be hard to eat. They may have suicidal thoughts. And we want to connect these people, obviously, to treatment as soon as possible. Postpartum depression often presents in the same way with people with a history of depression, but the reason that I think about it a little bit differently is that these people who we know during pregnancy have a history of depression, we can be doing things before baby comes to prevent postpartum depression. So women who are taking medicine for depression and find out they're pregnant and stop medicine have a 50% chance of a relapse of depression during pregnancy. Some studies show this relapse rate being even higher than 50%. And we know that the number 1 risk factor for postpartum depression is depression during pregnancy. So the more we can do on the front end, both educating people before they become pregnant. I realize if you're in the OB space, you're probably not necessarily meeting them before they're pregnant, but before they become pregnant, to tell them that they do not need to immediately stop medicine, that when they become pregnant, that they may choose to stay on, that we should have more conversations around this, and encourage people to do whatever else they can to stay well during pregnancy. The most commonly prescribed medicines during pregnancy for depression are the SSRIs. And the SSRIs have the most study of any medication during pregnancy. And while there certainly are potential risks to these medications for baby, the majority of these risks are small and many of them are transient. So when we're talking about risks of medication during pregnancy, we really need to be weighing those against the risks of untreated illness on both mom and on baby. Obsessive compulsive disorder, or OCD. OCD is 10 times more common in the postpartum period than at any other time in a woman's life. And it is often characterized by intrusive thoughts, intrusive worries about the safety of baby. So mom may be worried about harming baby, about baby not getting enough food, about sexually inappropriately touching baby. And these are extraordinarily distressing thoughts. Some mothers may even not want to be around their baby because they're afraid that they will act on these thoughts, but they are at no increased risk of acting on these thoughts than someone who didn't have the thoughts to begin with. So they are not at risk of actually harming their babies. One of the important things to know about OCD is that it responds best to SSRIs as well as specific forms of therapy like exposure response prevention therapy, and that oftentimes higher doses of SSRIs need to be used in OCD than in depression or other psychiatric disorders. And so if you meet a pregnant person on 80 milligrams of fluoxetine or on higher than FDA recommended max doses of sertraline or escitalopram, this person may have a history of OCD, and by decreasing their dose, you may be at risk of worsening their illness. And there really is not data that suggests that dose of SSRI correlates to an increased risk to baby. So there's very little to be gained by simply decreasing someone's dose. Post-traumatic stress disorder I have it on this slide for a couple reasons. One is that certainly there are people who can have very traumatic birth experiences and go on to develop post-traumatic stress disorder. And separately, there are people with a history of trauma in the past, especially sexual trauma, that can make the birth experience more difficult and stressful. But post-traumatic stress disorder is a really specific disorder in the DSM, the Diagnostic and Statistical Manual, which tells us, how to diagnose mental health disorders. And a lot of people who have trauma may have depression or other disorders. And so I want to take a minute here to talk about borderline personality disorder. Borderline personality disorder is a more pervasive condition that develops over time. And the way I like to think about borderline personality disorder, I learned about it in my favorite book about borderline personality disorder, which is the Borderline Personality Disorder Survival Guide. And in that book, they divide the symptoms of borderline personality disorder into 5 arenas of instability. So people have instability of emotions. Their emotions can go up and down relatively quickly in response to what would be seemingly minor things in the environment. Behavioral instability. So this is impulsive behavior. It may be around spending money, around sex, around substance use, eating disordered behaviors, self-injury. Instability of relationships. People may stay in relationships that are seemingly unhealthy because they really don't want to be alone. Their relationships may appear chaotic. Instability of the self, not knowing who they are, feeling chronic feelings of emptiness, and instability of the environment, meaning that they may actually lose touch with reality, they may dissociate from reality. And borderline personality disorder, when I talk to this about patients, it has, I think still, unfortunately, a stigma associated with it. And people, I think, believe it's more enduring than it actually is, meaning if you look at people over time with borderline personality disorder, there are a lot of people who get better and no longer meet criteria for the disorder. So it is not necessarily something that people have for life. As people get older, sometimes they enter into more stable relationships. Even without treatment, things can change. But it often comes from either an unsafe, traumatic early environment. About 75% of people with borderline personality disorder have a history of early childhood trauma, or perhaps a parent-child mismatch, an invalidating early environment. And if you are growing up in an environment where you are afraid of being hurt, whether that be somebody actually physically hurting you or being cruel to you, you learn to be on alert and look around and see what other people's emotions are because you want to protect yourself. And we are already wired for danger. And so if you have this early environment that you are even more wired for danger, you get really, really good at reading people's emotions. The problem is you don't know what they're thinking and you're not psychic. And so what will often happen is someone with borderline personality disorder will be able to read on someone's face that they are upset. And then they will think, oh, they're upset with me. And that will cause anxiety. So one of the challenging things about borderline personality disorder is that you can have both borderline personality disorder and bipolar disorder, but the symptoms can sometimes be difficult to tease out. And so I'm going to talk a little bit more about bipolar disorder, and I just want you to keep this in mind as we move forward. Bipolar disorder, a mood disorder where people have episodes of mania or hypomania, as well as episodes of depression. And one of the challenges with screening for depression in the postpartum period is if you have someone screen positive with the EPDS and they're in a depressive episode, what it doesn't tell you is whether or not they have bipolar disorder or major depression. And in terms of treatment with medication, the difference is really important because people who have bipolar disorder, their depression is not as likely to respond to the first-line medicines we use in major depression, the SSRIs or bupropion. In bipolar disorder, we use medications like lamotrigine, as well as the atypical antipsychotics. So I'm not asking you to be able to make this diagnosis, but it is an important thing to be thinking about when you're talking to patients who screen positive with the EPDS. And then postpartum psychosis. Postpartum psychosis is rare, but it is a psychiatric emergency. There's an increased risk of suicide and infanticide with postpartum psychosis. The majority of people with postpartum psychosis will not harm themselves or harm their babies, but because of this increased risk, we want to be usually hospitalizing people who are in a postpartum psychosis episode. So this graph really underscores how high risk the postpartum period is for mental illness. This graph shows time over the course of a woman's lifetime according to reproductive cycle and inpatient hospitalizations. And as you can see, pregnancy is not a time of increased risk, but the postpartum period, especially those first 3 to 6 months, are extremely high risk. And in this graph, it's looking at inpatient hospitalizations. This is mostly represented by women with postpartum psychosis. But the majority of women who have bipolar disorder will fall into a depressive episode postpartum. This graph is from a study by Adele Viguera looking at women with bipolar disorder and just following them naturalistically over the course of pregnancy. And the top line, the purple line, are people who maintained their treatment. And that bottom line, the orange line, are people who stopped treatment, stopped medicine. And as you can see, for the women who stopped medication to treat bipolar disorder, almost all of them relapsed into a mood episode during pregnancy. This is even before the postpartum period. And the majority of these relapses were into a depressive episode. So that really underscores just how important it is to have conversations with people about continuing medicine and treatment during pregnancy. Even though medications for bipolar disorder, some of them are known teratogens, and some of them we don't know a lot about, although we are learning more. This questionnaire, the mood disorder questionnaire, I show you not because I think you should implement it in your practice, but because I think you should be aware of it, because there are algorithms that use it, and I want you to know about it and know about its limitations. So this questionnaire, it's 13 questions, and it asks about symptoms of bipolar disorder. Have you had times where you felt really good, almost too good, and other people noticed? Have you had times where you got really irritable and started fights or arguments, shouted at people? Have you had times when your thoughts were racing so fast you couldn't keep track of them? Were you easily distractible? Were you spending more money than usual that caused problems? A positive score on this questionnaire is answering yes to 7 or more questions and endorsing that they happened at the same time. That's question 2. And then on question 3, saying that they caused at least a moderate problem, so a moderate or severe problem. The challenge with this questionnaire is that, as you can see, when we think back to the symptoms of borderline personality disorder, some of the symptoms in here are also symptoms of borderline personality disorder, having irritable outbursts when something upsetting happens, or being impulsive in terms of spending money, or having sex. And so it doesn't differentiate the two. And so this questionnaire is, depending on what population you use it in, its sensitivity is not very high. Its specificity is quite high. So if someone scores negative on the mood disorder questionnaire, they could still have bipolar disorder, but it's less likely that they do. But if they screen in, if they answer yes to these questions, because bipolar disorder isn't terribly common, you're going to have a lot of false positives. And so you don't necessarily have a ton more information with a positive screen on the mood disorder questionnaire than you did before you asked the questions. You still really need to figure out whether or not this person has bipolar disorder. And that's hard to do. What I would say is that when we think about the problems that misdiagnosis of bipolar disorder causes people over time, what is usually cited is the delay to diagnosis. And so it's problematic if someone has bipolar disorder and they get started on an SSRI and then on bupropion and then perhaps on another antidepressant and they don't get better. And then finally someone realizes they have bipolar disorder and puts them on something that helps for bipolar disorder and they get better. We wish we didn't miss all that time. But what has not happened is it is not terribly common. It's not that it can't happen, but it's not terribly common that people get put on an SSRI and have a manic episode. And that is often what causes practitioners to be afraid of starting someone on bipolar disorder on an antidepressant. But the data about manic switch on antidepressants, a lot of it comes from the older antidepressants, nortriptyline, amitriptyline. And the SSRIs, again, it's not that the risk doesn't exist, but it's certainly a lot lower. So if you have somebody and you're not sure whether or not they have bipolar disorder and you can't get them in somewhere quickly, perhaps they've taken SSRIs before, you could always try again and try to get them to treatment as quickly as possible. What you can always do, whether someone has postpartum depression from a unipolar episode, from a bipolar episode, is you can prescribe sleep. There are studies that show that simply getting people to sleep a good chunk of time in the postpartum period can put people into remission from depression. So I try to talk to all of my patients. Again, all of my patients are people who have a pre-existing mental health condition. I talk to them all about trying to preserve a chunk of sleep, 4 to 6 hours. And that usually involves a support system so that someone else during that time can be waking up with baby, perhaps feeding baby, and mom can pump, or they can, bring mom the baby to feed and she can feed and then just immediately go back to sleep and not have to do all the other care surrounding getting baby, diaper changed and all of that. So this is something that we can do for everybody and is really important. And of course, we want to refer. So there are a lot of options in terms of level of care in psychiatry. Oftentimes people think about inpatient care, locked inpatient unit, and outpatient care. I'm taking medicine and I'm perhaps seeing a therapist once a week. But there are a number of levels of care in between those two. There are partial hospital programs and intensive outpatient programs. These levels of care are very similar to one another. They involve going to treatment during the daytime. It's usually group treatment with perhaps a little bit of individual treatment mixed in, and you sleep in your own bed at night. Partial hospitalization is 5 days a week, and it is most of the day, and there is always somebody who is also prescribing medicine, either a nurse practitioner or a psychiatrist. Intensive outpatient programs are a little bit less time intensive. They usually meet 3 days a week for part of the day. And there are a lot of options, including in-person programs, as well as online programs. So there are virtual intensive outpatient programs out there if you live in an area where it's difficult for somebody to travel to actually go to a program. I talked before about skills building and dialectical behavioral therapy and cognitive behavioral therapy. And these are therapies that certainly can be done in the outpatient setting, and that is how they were developed, was in the outpatient setting. But oftentimes, partial hospital programs or intensive outpatient programs will involve skills-based therapies, usually cognitive behavioral therapy or dialectical behavioral therapy, or a mix of the two. And what dialectical behavioral therapy is, because you will see it probably a lot in this level of care, is it is a therapy that was developed by a woman, Dr. Marcia Linehan, who wanted to develop a therapy to help treat people who were struggling with suicidal thoughts and suicidal behaviors. And she ended up developing dialectical behavioral therapy, which has really great evidence in treating borderline personality disorder. And what dialectical behavioral therapy is it involves group therapy once a week, where people learn the skills. There are 4 modules: emotion, regulation, distress tolerance, interpersonal effectiveness, and mindfulness. And then they meet with an individual therapist once a week, where they work on putting these tools into action in their lives. And then they also are encouraged to reach out to their therapist between sessions, either phone calls or text messages, to get coaching on using the skills. And then there are support groups. So Postpartum Support International at postpartum.net has a number of online support groups. And these support groups are run by a moderator, and they are usually closed groups, meaning that you sign up and then you're with the same people week after week for a period of time until you kind of graduate from the group. And they have groups for all sorts of different people and situations. So you can be in just a general group, but they have groups for NICU parents. They have groups for partners, for dads. There's evidence that postpartum depression is more common in fathers and partners as well, because while they are not having the hormone shifts that women are having, they are having the stress of being a new parent. So these groups, you can sign up online and they are free of charge, and I would share this widely with your patients. So this perinatal psychiatric consult line is really important for you to keep handy if you are prescribing medicine or working with somebody who's prescribing medicine. So this is a consult line for people who prescribe medication. So patients cannot call this line. But if you are a medical provider and you have a question about a patient, about perhaps starting them on a medicine, restarting them on a medicine, you can call this number and you can set up an appointment and you can talk to a perinatal psychiatrist for free. And so this is a really great resource that PSI offers. Massachusetts General Center for Women's Mental Health has a website that I also find very helpful. I have signed up on this website to receive their weekly blog, which I always enjoy reading. And I also often give this website to my patients who want to learn more about the safety of medication during pregnancy. The blog is it's written by Dr. Ruta Nonax, and it's usually written on a recent research study or some new information that has come out, and it is written really with clinicians in mind, but our patients can read these as well if they want to. And MGH now has what's called virtual rounds. So prior to the pandemic, the perinatal psychiatrists at MGH would talk to each other about their cases. And when COVID hit, they realized they could open this to the world. So every week they go on Zoom on Wednesday afternoons, and you can sign up. You just have to sign up once. You will get a link to join their Zoom session, and you can just sit and you can listen and observe, or you can bring your own case if you have questions. And I have always learned a lot simply from listening. And there are more training opportunities at postpartum.net. There are also some online trainings. And the other thing at postpartum.net that I failed to mention is the provider directory. So if you go onto the website and look at the information for providers, you can find provider directory, and you just put in your location and it will show you therapists, doulas, psychiatric nurse practitioners, psychiatrists in your area, and it says whether or not they take insurance and whether or not they are in person or telehealth. And you can find all sorts of resources. If you are looking on there and you're not finding anybody near you, you may want to simply open up the search for the entire state of Tennessee, because when people sign up on the directory, they have to list a location, but they may be offering telehealth. And so they may be listed as being in Nashville when they actually could see somebody in Memphis or Johnson City. So I encourage you to use all of those resources. Thank you so much for listening to me today. If you have other questions, please don't hesitate to reach out to me. My email is here. If you have trouble reaching me, you can always reach out to someone in leadership at TIPQC and they can get you in touch with me.